Today I will discuss the acute cholecystitis. This case relates to a 60 years old man with the chief complaint of the right upper quadrant pain for the last 3 days. Beside other investigation, the blood CP showed severe leukocytosis, while there was no fever. The ultrasound was ordered, and the following images are the result of the scanning. In this image, we can see that the gallbladder is distended. There is a calculus impacted in the GB neck. The wall of the GB is thick. Here we can also appreciate the thickened wall of the gallbladder. In this image, there is increased vascularity surrounding the GB wall. And there was a positive sonographic Murphy sign. Ultrasound is the initial imaging modality of choice in patients with suspected acute cholecystitis. The following ultrasound findings are suggestive of acute cholecystitis. The most important one is gallstones or cholecystitis. And oftenly, these calculi are impacted in the gallbladder neck or in the cystic duct. The positive sonographic Murphy sign is also an important clue for diagnosis of acute cholecystitis. The gallbladder distension or enlargement more than 10 centimeter in longer axis is diagnostic. GB wall thickening greater than 3 millimeter is indicative. And if there is pericholecystic fluid, it is also indicative for acute cholecystitis. Among these 5 signs or findings, the first two, which is the gallstones or cholecystitis and the positive Murphy signs, are most specific findings. In this image, we can see that how to check the Murphy sign. Basically, the sonographic Murphy sign refers to localized tenderness directly over the gallbladder, and it is positive when pressure applied with the transducer or probe elicits maximal tenderness over the GB visualized at scanning. The combination of gallstones and Murphy sign has a positive predictive value of more than 90%. The sign may be absent in non-responsive patients when pain medication has been administered or in case of gangrenous cholecystitis. Thickening of the gallbladder wall occurs to some degree in most cases of acute cholecystitis. However, many other causes of the gallbladder wall thickness exist beyond the cholecystitis, so it should be considered as a non-specific or less specific sign. Pericholecystic fluid is found in approximately 20% of patients, and its presence implies a more advanced type of cholecystitis. It is usually seen as a focal collection adjacent to the gallbladder wall. In this image, this is the stone with the posterior acoustic shadowing. This is the wall which is thickened, and this is the pericholecystic fluid. Gangrenous cholecystitis is severe advanced form with increased morbidity and mortality rates. Ultrasound hallmark for the gangrenous cholecystitis is presence of heterogeneous or striated thickening of the gallbladder wall, which is often irregular, with localized disruption or projection into the lumen of the gallbladder. Morphine may be absent. Intraluminal membranes in wall disruption are more specific but less frequently present. Another type is emphysematous cholecystitis. It is also a rare complication of the acute cholecystitis, and this is associated with the gas-forming bacteria. Up to 50% patients may have diabetes. Gas may be intraluminal or intramural. Intraluminal gas can be recognized by the anti-dependent gas echoes within the lumen. Another type is acalculous cholecystitis. Acalculous cholecystitis occurs in extremely ill patients. Ultrasound is often echoical because these severely ill patients have distended thick-walled gallbladder even in the absence of inflammation. Morphine is unreliable in these patients. To discuss the imaging findings, ultrasound showed sign of acute calculus cholecystitis. The patient underwent emergency for open cholecystectomy. Acute inflammation and wall necrosis, especially gangrenous cholecystitis without gallbladder perforation, was observed at surgery and on histological examination. Thank you very much for watching. Hope you have enjoyed.